Welcome to Voices in Value-Based Care. I'm Matt Fusan. Thanks for tuning in. A note before we start today's show, SPH Analytics Population Health Division recently merged with another leading population health company, Azara Healthcare. We will be using Azara Healthcare as the name of our new company moving forward. You can learn more on this at azarahealthcare.com. You can follow the show on Twitter at hashtag Voices in VBC as always, and follow Azara Healthcare on Twitter at Azara Drives, which is Azara, AZARADRVS. On the program today, I'm talking with A.R. Weiler, Chief Executive Officer of SonarMD. Welcome to the show. It's great to have you.
Great to meet you, and thanks for the opportunity, Matt.
Absolutely. We are very interested in hearing about the tool SonarMD has developed to help manage care coordination for high beta chronic conditions such as Crohn's disease and ulcerative colitis. But first, why don't you tell us a little bit about yourself?
Yeah, thank you so much. I started my career in Silicon Valley at a small, at the time, software company called Oracle. I was there more than 15 years. Towards the end, I became a leader of Oracle's healthcare business and really fell in love with healthcare. The complexity, the opportunity to improve the efficiency, and especially the mission that helps people receive the very best care. Subsequently, I held leadership positions at Optum Insight, at Virgin Pulse, and also at Change Healthcare. And in 2012, I became CEO of a company here in Minnesota called HealthSense. We essentially developed passive remote monitoring for patients, creating this category and improving the efficacy of this. The company was sold to Great Call, which is a cell phone company that focuses on seniors, and is actually now part of and a pillar of Best Buy's health division. After that great experience, I consulted with Verily, which is Google Life Sciences, and also Google Health for several years on emerging projects. Then I was actually recruited into Stella, which is the parent company of Blue Cross and Blue Shield of Minnesota, to build a palliative care business called Livio Health, and this is really exciting. We grew it from 0 to 550 patients in a little over 16 months, and we had a holistic care model that focused not only on medical care for patients with serious illness, but also other elements, social determinants of health, but also spiritual, psychological, and behavioral, et cetera. So it was really, truly a new care model that helped these patients and families at a very difficult time. And our goals in the case of Livio were to lower cost and also provide a really great experience for these patients going through a tough time. And you'll kind of hear that as a theme when we jump over to Sonar in a moment. I left Livio in November of 2020 and joined Sonar a month later as CEO. And over here, we're building a digital care coordination platform that utilizes proprietary data analytics that we've developed and algorithms to identify early clinical deterioration of patients with inflammatory bowel disease, so specifically Crohn's and ulcerative colitis. Our goals, again, are to lower total medical expense and increase the quality of care received by these patients.
That's excellent. Super interesting and well-rounded background in the health IT space. Thank you for that. Let's dive in. Let's talk a little bit more about some of those things. So, for well over a decade now, you've been involved in building healthcare businesses focused on new ways to provide patient care. So not the classic clinician office or acute setting. Do you expect the expansion of new care delivery models will continue? And what do you think the impacts to patient outcomes and cost of care are going to be from that?
Yeah, that's a great question. I think we're really entering an amazing time right now of innovation. So the short answer is yes. And I think what's driving this are a number of things. First of all, the availability of new data capabilities, analytics and connectivity in particular. The analytics are enabled by some really amazing capabilities, predictive model capabilities that are out there generally in other industries, but we're using them in healthcare now. And the connectivity is driven a lot by the availability of data finally in EMRs that's becoming available broadly. And this is through a number of EMR companies making it available, but also through some legislation, as we all know, to encourage and mandate interoperability and connectivity. I think another couple of areas that are causing this acceleration in new healthcare models are the focus on value-based care over fee-for-service. So as many of you know who are in healthcare, we have a fee-for-service model largely where physicians and providers are paid for doing things, and so you get what you incent. We have a lot of procedures
That's
that
right.
happen, and value-based care really starts to realign those incentives so that people get paid based on outcomes, and typically the outcomes are quality of care and patient satisfaction metrics. So did you cure the patient? How long did it take? And frankly, what kind of resources did you need to do that? And it's a fundamental change that's happening in healthcare, and I think it benefits not only the patients and their families, but also it supports the long-term sustainability of healthcare as in terms of affordability.
The data's been out there, and we've talked about it a number of times on this podcast around, how much of a person's health is dictated outside of the care setting, right? Or
Right.
the classically defined care setting. So that aligns with kind of what we've known for a long time, but finally there'll be some payment models that make it feasible for people to do this, right? As opposed to saying, well, it works, but the payer isn't going to do it on my fee schedule, so I can't really do anything about it. That's super interesting and creates a lot of opportunity.
Yeah, I agree. And payers are really getting innovative themselves. They see a number of reasons to adopt value-based care because in the end of the day, the payers aren't existing in a vacuum. They need to serve not only the employers that typically they provide the services for, but also their own populations. And so they're looking for ways to be more efficient and really deliver more value. And a couple of other areas that are really driving this innovation. There's a number of general models that are evolving today. So primary care models, urgent care models, and then home-based care models. There are many companies out there. I won't mention all of them, but there are a number of companies that are doing this, that are going public and getting some really great traction. And that's as opposed to specialty care models like Sonar. So Sonar focuses today on inflammatory bowel disease. You think it's a small market, but it's actually about a 1.5% of the U.S. population, and they have it for many years. We'll talk about that in a couple of minutes. So I think these specialty models are kind of a new area and certainly a valuable area. But key to all these models, and what's really critical, I think, for them to be successful, is patient and family trust. You need to develop the trust with the patients. You need to reinforce it and make sure that when the opportunity comes up, you demonstrate the commitment that we have to the patients and families. And that is, as we know with many things with trust, it takes a long time to build and sometimes seconds to destroy. And so we work really hard to make sure we're consistent, and we work with partners that are consistent in building that trust and really delivering a great experience and great value for the patients who ultimately have to pay for this insurance and their coverage as well.
And that's interesting that the patient and family trust part makes sense, right? It just at the core makes sense, but I can tell you through a lot of conversations, patient outcomes, a lot of discussion, but I wrote down patient and family trust specifically. I think that's a hugely important component that maybe doesn't get enough discussion in this, current atmosphere as we're trying to make the transition. Without the trust of the patient accepting these new care models and understanding they're beneficial, et cetera, it's not going to really work at the end of the day.
Completely agree. And again, it's something we focus a lot on in my previous companies, HealthSense and Livio, and we're spending a lot of time on it in Sonar as well to build those trusted relationships at the patient level, but also at the provider level. We're working with GI practices and their teams, and we really, as you'll hear in a couple of minutes, we really provide a conduit that all parties appreciate and ultimately they trust.
And, you touched on this a little bit just a second ago, and this is changing more and more, especially for those of us in the industry. But if you step out of the industry, I think maybe there's still a pretty high level of thought around, hey, payers and providers are adversarial relationship, right? Mm-hmm. And unfortunately, for many decades, that was truly the case. But the relationship is starting to change, and many of the new models you kind of referenced, right, and talked about are being built explicitly for payer and provider collaboration. Tell us about the benefits of collaboration for both parties, and then most importantly, as we've talked about, right, how does it impact the patients?
Well, Matt, as you say, this has been an unfortunate legacy at times between payers and providers. It doesn't happen all the time, but it's happened more often. It's been documented elsewhere, and so I won't go into that here. And we really see that kind of as the old model. But as you said, things are changing, and I believe, better patient, provider, and payer collaboration is already taking place, really focused around the concept of what's in the patient's best interest. Broken into short, medium, and long-term initiatives. This could be, short-term, we're addressing the illness and chronic conditions as efficiently as possible. Somebody presents and we say, gee, what can we do to help cure that patient? And that's what a lot of healthcare has been today. Somebody is sick, they go to the hospital, the emergency room, patch them up, send them home.
Right.
There's a medium-term impact as well, and we believe that's minimizing and attenuating their illness or chronic condition. You can sometimes anticipate it. We do that at HealthSense. We did it a little bit at Livio. We're absolutely doing it at Sonar, and it's exciting to see us predict when people are beginning to get sick, and being able to take action early, whether or not it's care or maybe adjusting their drugs. It really does drive lower total cost of care and avoid some episodes. And again, that benefits all the stakeholders here. And there's even a long-term component as well. We think, through early detection and action, we can prevent the progression of disease, in our case, IBD, Crohn's, and ulcerative colitis, and have a tangible impact on the healthcare inflation, which makes healthcare more affordable. So we think we can, and the evidence is showing what we're doing at Sonar, that we can have a material long-term effect on these patient populations. But collaboration, as I've kind of stated here, it actually benefits all parties. The patients get better care. It's lower cost to them through deductibles and premiums, and so it's really a win for them. Providers, the impact is freedom to practice without interference. This has been at times kind of the things that they've complained about payer. Why are payers telling me what to do? Why are they denying care through utilization management?
Right.
We understand why payers are doing that, but by adopting some of these preventive, anticipatory technologies like Sonar presents, it really gives providers more freedom to practice medicine and use their experience, which we think is really important. And then kind of, payers and self-insured employers, it lowers costs for them, makes healthcare more affordable, and it allows them to provide broader coverage. And again, that's kind of the mission that they're on. There's a tension. There's always going to be a tension between these parties, but understanding that and a capability like Sonar to kind of come in and help address all those needs simultaneously. It's a really nice story, really nice platform to deliver that on.
Absolutely, and I think to your point, not only do those three benefit, but the general economy of the United States, right? As we know, where so much of our GDP is flowing toward healthcare and continues to go up. So it's not just those three entities that definitely have a benefit from it, but all of us. One of the models that we have talked about, and as we were prepping for this, we're talking is, and we're seeing more and more out there, is the acronym RPM, which stands for Remote Patient Monitoring. This has kind of been out there and touted as a possibility for many years now, right? Since, let's call it Apple Watch version 1, the wearables, all that sort of stuff. But it definitely hasn't taken hold, I think, as much as people thought it would early on. But we're starting to see it now really produce models that are clinically relevant, right? And that was always kind of the challenge. It's like, okay, you can send me all this data, but is there anything I can do with it? Tell us what, for the audience, as you would define remote patient monitoring, and the impact that's going to have or is having on outcomes and total cost of care.
Yeah, absolutely. So when you go to the doctor's office, usually the check-in process once you get in is they walk you over to a chair, you sit down, they take your blood pressure. They ask you to get up on the scale, take your weight, measure your height typically. They might do other things kind of in the intake process. That's what patient monitoring is. That's kind of that idea. And the remote patient monitoring simply is, can we perform those activities in someone's home or more frequently than we're doing for those office visits? So even the most active patients typically are only at their doctor's office every 3 to 6 weeks. What about the other times that they're at home and doing that? And so that's the promise of RPM, or remote patient monitoring. And it's data that most clinicians know what to do with. We all kind of know if a blood pressure rate is too high, what we should be doing, if it's an emergency situation, or we should just maybe treat it with drugs. Or if there's a sudden weight gain and someone has congestive heart failure, for example, we know what that means. We know they're taking on fluid and it may cause some issues. So it's a well understood intervention, as they would say, of medical professionals based on the data. So the benefit of being able to do remote patient monitoring is you can get continuous data, in theory, from somebody in their home. They walk up to it every morning or maybe every other morning, take their blood pressure, send their weight. And these are connected devices that typically, through an encrypted connection, high security connection, send this data in so that their clinicians can look at it and monitor it. And you get the benefits of trending over time, not every 3 or 6 weeks, et cetera. And again, can trigger alerts when they happen. There actually are two types of remote monitoring that now kind of are in existence. There's the traditional active remote monitoring that I just described. So you got to take your blood pressure or your weight. And then there's a new category. We developed it actually at HealthSense called passive remote monitoring. And the active is you actually have to do something. And it turns out sometimes people don't want to do that. So then you start making phone calls and reminding Mrs. Jones, hey, we didn't get your blood pressure reading this morning or your weight, so could you please do that? Right. The nice thing about passive remote monitoring is it exists in your environment, and there are ways to pick up on the data. It may not be blood pressure, but it could be things like sleep or how often you're eating or how often you're moving or time that you're spending moving around the apartment or whatever. Right. And that's a nice thing. And the benefit of passive remote monitoring, which is growing today, is it happens automatically. You don't have to remind people to do stuff. And so showing that method actually catches these early indications of a chronic condition exacerbation is really valuable. So, but the challenge is it's not always understood by clinicians and like blood pressure data is, for example. So, but in all cases, you have kind of the dual goals here of, can we detect people getting sick, sometimes even before they know it, and therefore reduce total cost of care because you're able to get them in to see their doctor rather than have them go to a hospital or emergency room. Right. And what do they think about it? Do they like it? Does it allow them to stay in their homes longer? So patient satisfaction is really important too in this environment. So those are kind of the dual metrics that you use to monitor any system like that. And frankly, what we use at Sonar as well.
And, back to your trust comment, not just patients, but doctors and clinicians. That's a great point here, right? Do the doctors and clinicians trust that this kind of passive monitoring is meaningful and getting them on board as much as the patients? And I think one of the interesting components that you called out at the end there is patient satisfaction, right? Being able to stay in your home longer and the patient satisfaction starts going up. And that's a bigger and bigger component of value-based care contracts, as we know, flowing into the future here. So it's going to be interesting as those expand. Plus, the level of seniors in our country, right, is continuing to expand, and the number of people to care for them is flatlined at best, and in some cases possibly, going down. So this type of thing is just going to become more critical.
Yeah, absolutely. Not only the labor, but 93% of seniors want to remain in their home through end of life, and really only 83% do. Those that 10% go in typically into senior living facilities, assisted, independent, skilled nursing, and memory care. And as you point out, there's a huge labor shortage. Also, these communities can be expensive at times. So keeping people in their homes as long as possible is really the goal that we had at both Livio and HealthSense, and it was something we were able to clinically demonstrate using third-party data. So it was an exciting time to develop that, and those programs continue to live on through Stella, which is the parent of Blue Cross of Minnesota for Livio, and Best Buy Health is now has Lively Home, which is the HealthSense product kind of evolved to the next level. So it's exciting to see those capabilities continue and really develop even further.
It is. And, let's take some time now. Tell us about SonarMD. Tell us about, what you guys are doing, product, services, how you're delivering, how you're working with the various stakeholders we've talked about up to this point. Floor is yours on that.
Yeah, thank you. SonarMD is a digital care coordination platform that utilizes patient-reported data and proprietary analytics and algorithms to identify early clinical deterioration of patients with inflammatory bowel disease. So specifically Crohn's disease, as well as ulcerative colitis. And this causes substantial economic burden to our healthcare system today. These are very expensive patients, as I'll talk about in just a second. So our goal, again, similar to my background, is to lower total medical expense or total cost of care, and simultaneously increase the quality of care received by these patients. And a lot of industries, cost versus quality are opposed. Healthcare is one of these rare industries where you can have both, and it's exciting to deliver that, and we are delivering that. So the Sonar platform, proactively identifies and also stratifies, so kind of ranks these patients when we believe they're getting sick, often before they realize it themselves, because people with IBDs tend to normalize their symptoms. It's like the frog in the pot. They don't realize it's getting hotter and hotter,
right,
and pretty soon it's boiling, right? Once we determine that, Sonar coordinates care with your GI physician. So it's a really natural thing. We're just getting them in to see their physician maybe a little bit earlier. And doing this results in a reduction in avoidable high-cost emergency room visits, hospitalizations, and even surgeries sometimes. So it's a pretty impactful intervention. We can also help them with their drug optimizations. So pretty much all these folks are taking some kind of biologics or other drugs, including site of service. So maybe they get their infusion at home or in the doctor's office, not the hospital. Choice of drugs, dosage, and also formulary adherence. So are they actually taking the drugs that will have the best impact for them? So the way Sonar works is we actually contract with healthcare insurers first, and then we work with GI practices that are in these insurers networks to bring cost and quality benefits to all the parties as we've outlined, especially the patients with IBD, because these patients have a deductible typically, and we can help them manage that. So to date, we've shown that the Sonar platform lowers total cost of care by more than 15%. And this is on a population that costs on average of about $40,000 a year. So 15% or more, $6,000 or more of expense, or more than $500 a month.
Yeah, that percentage, if knowing these types of things, that's a huge percentage.
It is, healthcare. And it's demonstrated in the data that we have today. So it's really exciting. We continue to review that data and make sure that we're continue to deliver those results as we scale the program, which is always important. So the challenge is not just the annual cost, Matt, as you just mentioned, but also the fact that IBD patients, they're typically diagnosed with Crohn's or UC in their 20s and early 30s. And kind of given our lifespans today, this means they're going to have it for the rest of their life. So decades of this cost, and especially their discomfort, can be addressed by the SonarMD platform, which both helps patients and GI physicians. They both value it because of the impact that we can have on both cost and also the quality of care. So finally, it is the simultaneous pursuit of these objectives, like I mentioned, lower total cost of care and higher patient satisfaction. This is what really excites me about the work we're doing at SonarMD, and why I'm happy to speak with folks today about this capability, because it is truly revolutionary to be able to accomplish both of these things simultaneously. And we're showing we can do that today with SonarMD.
So if I am the patient, how am I interacting with SonarMD? Is it via an app, a person? Tell us a little bit about that from a patient perspective.
We're all a collection of our experiences. And so one of the things that we've done at SonarMD is make it as easy as possible for people to interact. Just like I mentioned at HealthSense, prior to that, people need to make phone calls to ask people to get their biometric measurements. We just automatically pick them up in HealthSense. Well, Sonar's done exactly the same thing. We actually enroll the patient in the program, and we send them an email or push a text to them. And it's a simple kind of 5 to 10 question survey that they answer. They can just answer it on their phone. And we get a really high level of compliance with that. We have typically 70 to 80% of the people that are eligible for our program get enrolled. That's a phenomenally high rate. And when I got here, I looked into it. I was like, how are we able to drive such amazing engagement? And it's that we've made it as easy as possible, as frictionless as possible to do that without annoying them. And that balance is just really critical here. So we've really kind of scaled it over time to be able to do that. So it's exciting technology that's really proving efficacy quite well.
And then, do patients ever speak with anybody in your organization? Is it technology only, or are there some individuals that they can also speak to prior to you guys engaging the GI practice?
Yeah, well, great question. And back to trust, we feel that, once they respond to a survey kind of electronically and it creates a Sonar score that's sufficiently high, we reach out to them and kind of do what's called a triage process, where we do have a conversation with them. So we have care coordinators. They're not nurses, but they basically learn a little bit more about what's going on, and then they make a warm handoff to their GI physician in practice that they already know. So it's a really comfortable interaction. And again, we're not providing any care. We're just helping to get them in to see the right people at the right time when they need it. And so that piece of it and building the trust relationship is really critical.
Yeah, and I think, that's part of when we were talking made it really interesting to me. It's not just a technology for somebody to buy and push out and then your company is out of it. It's that warm handoff and that making sure people are comfortable. I think more and more starting to see models that are a little bit blended, right? Yeah, technology is a driver, but then that human element that I think we tried to remove for so long is just critical. It's critical, and I think your company is a good proof of that.
Well, thank you. It's a really important point that we've learned in the past, which is if you're technology only, you can, in theory, scale the company, but you don't have a lot of loyalty and you miss the trust factor. Yeah. And so the warm human voice that comes across, and we won't bother you unless there's really an issue that we need to, you start to build those relationships up over time. And it really needs to be a good balance, as you pointed out, between technology and the human factor. And then we're not trying to disintermediate them from their GI docs. We just get them in to see them earlier. And sometimes we even help them kind of navigate that process. So It's a great platform. It's poised for pretty significant growth here in 21, and we're excited about it. But we're always kind of checking that balance to make sure we're delivering the value for the patients, as well as delivering a service that's appreciated by the GI physicians and practices.
Excellent. Well, as I say at the end of every one of these, I wish we had more time because amazingly, we're already at time. So Thank you, AR, for joining us today. Really appreciate the conversation.
Yeah, thank you, Matt. This has been great to talk a little about SonarMD and what we're doing. And thank you for this radio program. It's exciting and great opportunity to share innovative developments in the value-based care market.
Excellent. Thank you. And as always, for our audience, you can learn more on the programs page at healthcarenowradio.com and lend your voice to the conversation on Twitter at #VoicesInVBC, and be sure to follow Azara Healthcare on Twitter at AzaraDRVS. I'm Matt Fusan, bringing you the voices in value-based care you should hear. Until next time, have a great week.